So welcome everyone to Grand Rounds. Before introducing today's speaker, there's an announcement that I wanted to make. So it's really a real pleasure and an honor to announce that Dr. Claudia Lugo-Candales has been named the inaugural Estelle Bender and Richard Fishbane Scholar. This is a new position that's been made possible by a generous gift from a longtime friend of psychiatry at Columbia, Estelle Bender. As many of you may know, Estelle is an alumna of Columbia Medical School. She also did her residency here at the Psychiatric Institute, and she's currently on voluntary faculty within the department. Estelle serves on the Columbia Psychiatry Board of Advisors and has been a consistent and strong supporter of young investigators, particularly in child psychiatry. That includes David Pagliosio, as well as Joel Bernanke. We are just incredibly grateful for her support. And even though Estelle is not a child psychiatrist herself, we absolutely consider her an honorary member of our club. The Bender-Fishbane Scholar position provides awards to assistant or associate professors within the Division of Child and Adolescent Psychiatry, with a preference for those working on youth suicide or mental health in underserved minority communities. You could not really think of a better fit for the first Bender-Fishbane Scholar than Claudia Lugo-Candales. Claudia is an assistant professor within our division, and her research interests are to better understand early development of inhibitory control difficulties, particularly within developmental disorders such as ADHD. In 2016, Claudia joined the Division of Child and Adolescent Psychiatry at Columbia as a T32 postdoctoral fellow. And despite terrible mentorship from some Jonathan Posner, she, in spite of that, has been remarkably successful. As a postdoc, Claudia trained in infant neuroimaging methodologies, and she now employs these methods to understand early brain development using infant MRI to examine neural systems related to deficits in inhibitory control. Claudia is particularly interested in understanding how exposures and experiences during the prenatal period place offspring at risk for inhibitory control disorders. And she's strongly committed to understanding exposures and experience that are most relevant to underserved and underrepresented communities. So I cannot say enough good things about Claudia and cannot thank Estelle Bender enough for her support of this really rising star and to child psychiatry more broadly. So congratulations to Claudia, and thank you again to Dr. Bender. So it's also a real pleasure to introduce today's speaker, Dr. Milton Wainberg. And before I say a few words about Milton, I wanted to note that Milton has been awarded the Judd Marmor Award from the American Psychiatric Association. Because of the COVID pandemic, Milton wasn't able to give the Judd Marmor lecture at the APA conference. So instead is providing that lecture to us as part of our Grand Rounds. The Judd Marmor Award was endowed in 1999 by the late Judd Marmor. It was established to honor a distinguished member of our field who has contributed to advancing the biopsychosocial model within psychiatry. The APA's Committee on Research Award grants this award to individuals who have made significant contributions to understanding the multiple events involved in mental health and illness. Prior recipients of the award are a very esteemed group, including John Oldham, our own Eric Kandel, and Nancy Andreasen. And several members of the APA are on the call today, so welcome. We are very glad to have you here. So a few words about Dr. Wainberg. Milton hails from Venezuela and is an implementation scientist, an educator who does research and work focusing on public mental health systems of care and on training the next generation of mental health clinicians and researchers. Since 1998, Milton has led a research portfolio concentrating on the intersection of HIV, mental health, and substance use disorders among some of the most vulnerable populations across the globe. Since 2012, Dr. Wainberg has led a global mental health implementation program aimed at bringing evidence-based interventions within systems of care in low and middle income countries, as well as low resource settings within the US. His work has developed innovative training and research programs aiming to address gaps in the global mental health treatment and research in poor resource settings. So with that, it's a real pleasure to turn it over to Milton, and we're all very excited to hear your talk.
Thank you so much, Jonathan. It's a pleasure to, thank you for the intro, and it's a pleasure to be here and hopefully stimulate a little bit of combination of work between all of us in the department and others that may be joining. So first, let me share my screen so we can put the PowerPoint to work. And I'm imagining that people are seeing the PowerPoint, and I'm gonna put it in perfect. Everything okay? Just want to make sure. Great. Excellent. Let me just set it up. Okay. So again, thank you so much. So let's get started. So first, I'm honored to receive the APA Judd Marmor Award. As Jonathan said so beautifully, Judd Marmor's work in psychosocial, the biopsychosocial model is of relevance, and that's exactly why the work that we're doing in implementation science. I'm also, Judd Marmor was a Columbia University medical graduate, and also I have been always, he's been in my mind because he worked very hard on depathologizing homosexuality. So this Saturday is World Mental Health Day. So I'm hoping that today I will try to get to the goals that this day brings of awareness, mobilizing efforts, identifying what needs to be done to bring to practice mental health care. And there's some events that you can look at on your own in the website of the WHO. Oh my God, so many amazing people to thank. I enjoy my life dramatically. And as you can see from the slide, no wonder my agenda, my calendar is so busy. I do wanna, you know, besides the amazing people that I collaborate with at Columbia and at University of Pennsylvania, once Maria left to go there, I do need to talk about the Mozambicans. They are such an amazing group. They're amazing, dedicated, and fun group to work with and lead science and public mental health with almost no resources. You are incredible people, estamos juntos, and today's talk is going to concentrate on funding that we have attained for this. So I'm not going to talk about funding that I have with Kate Elkington and Ned Nunes or with Barbara Stanley. This is going to be concentrated on these grants. Okay, so what's the goal of today? I'm going to start talking about the burden of mental illness. So burden of an illness or the disability adjusted life year is measured by the summatory of years lived with the disability. That if an illness is chronic, then it creates disability, and the years of life lost due to the illness. So the impact of chronic illnesses like mental illnesses are big on years lived with disability. Although we also know that the lifespan of people get shortened when they have a psychiatric disorder. So I want to look at how mental and substance use disorders rank compared to other illnesses and rank geographically. And I'm going to use some examples. I'm not going to bring the whole world into this. So let's start with years lost to disability. Here is data from the Institute of Health and Metrics and Evaluation of University of Washington. It's a great interactive site. If people want to go, you have the site on the left bottom. And I'm going to show you first, this is data from 2017, the latest that they have, both sexes, all ages. And as you can see, mental disorders rank very high in comparison to other disorders. And in all of the countries, in globally, high income countries, low and middle income countries, the US, and I have also Mozambique and New York State, there for us to see based on work that I'm going to be presenting today. And the issues continue the same if you look at children, adolescent and young adults, and people in their working and functional time, and they're not so young like us. The conclusion is pretty clear. Mental disorders have a similar and the worst years lost to disability burden of any disease in high-income countries, including the US and New York State, and in low and middle-income countries, including Mozambique. And let's look at then now on the combination of the years lost to disability, years of life with disability and years lost to life, which is by early death, which is the combination of the two of them. And again, you can see that mental disorders are ranked very high in high income countries and lower in low and middle income countries in children. And when you get to young adults and people below 50, below 49, mental disorders are also very high, prominently in high income countries. So the conclusion here is that the overall burden of mental disorders is among the highest of any disease, and it's worse in the high income countries than in low income countries. So the burden of disease, this high burden is expected to worsen. And the important issue to think about that the worsening is that if people remain untreated. So we must do something now. We cannot wait. That's why there is a call to integrate evidence-based mental health services in primary care and to do early interventions to try to stop the burden of disease. So let's talk about the resources and the mental health treatment gap. So here you have a map of the world looking at the human resources for mental health, psychiatrists, psychologists, psychiatric nurses, and social workers per 100,000. And if you look at these, obviously there are some countries that look quote unquote pretty good in darker green, and some countries that are pretty low. Well, the reality is that low income countries have between 0.1 and 0.3 psychiatrists and psychiatric nurses respectively per 100,000. The ideal number is considered to be 45. The US is low, and Switzerland is a little better. So in high-income countries, there is a rate of psychiatrists that is 120 times greater than in low-income countries, and with regards to psychiatric nurses, 70 times greater. It's a complicated world. So let's talk about our country. You can see here that we're not doing much better. The map shows the distribution of psychiatric nurses in the US, but I want to point out that in 2015, a study showed that nearly 60% of all US counties lack even a single psychiatrist. In other words, rural counties would have 590 psychiatrists to serve more than 27 million Americans. We're talking about a huge treatment gap that then gets to be established. So if you don't have enough people to treat those in need, then you have what is called the mental health treatment gap. And you can see in high income countries, we're not doing great. It's between 35 or 50% of people who need psychiatric care are getting it. But in low and middle income countries, it's definitely worse. Between 76 and 85% of people who need psychiatric care are not getting it. So here we see just to look at how depression ranks in the US. This is a study by a friend in UNC, Brian Pence, and he calls it the depression cascade from the prevalent cases, recognized clinically, half of them, only half of those get treatment, then 9% get adequate treatment, and remission is only achieved in 6%. And according to the Academy of Pediatrics, as many as 2 in 3 youth with depression are not identified by other providers and don't receive care. We're doing pretty bad. There's something that we need to look at this and determine that we need to figure out how to improve our services. But obviously, there are some challenges to that. We have the evidence that is necessary to change these, but there are many challenges to implement them. So in this slide, we have the pipeline of how evidence reaches practice. It takes 17 years for 14% of new discoveries to enter day-to-day clinical practice. It is even longer for evidence-based therapies, as studies are conducted by specialists, which works against dissemination. As I pointed out to you, if you do not have the human resources to use these evidence-based therapies, that means that they're much harder to disseminate. So In the translational science continuum, we know that we can go from TC to T4, going from basic research, how it translates to humans, to patients, to practice and communities. So going a little deeper into this, if we look from the translational research, we use the T1TR to look at more what is basic research, preclinical studies, and clinical efficacy. Once you do the efficacy, it's when you want to move into the efficacy and go into more what would be translation into practice. So for medications, it's quite quote unquote simple, not so much, but definitely when you have pharma companies that can contribute to figure out how to disseminate it, it gets to practice and communities in a much easier way. And therefore there is impact. However, when you're looking at evidence-based therapies and behavioral interventions that, as I mentioned, are more complicated, to really be able to figure out how to include them within systems of care, we need to think of implementation, dissemination, and implementation science. Unfortunately, there is a lack of funding for that, and the reality is that very few novelties that are produced here reach dissemination and implementation. So evidence-based, developed in high-income countries, have been contextually and culturally adapted, tested, and replicated in multiple low and middle-income countries. However, the data on how to deliver this evidence in low and middle-income countries is extremely limited. And by the way, the data in high-income countries like the US is not great either. So I just want to take a look at the challenges and try to rank them not only in low and middle-income countries, but also in our own. So in order to do any type of this work, you have to have the epidemiological data and validated assessment tools and reporting systems. We're doing very good in the US. We have, everything more or less that we need to do that. The case is not the same in low and middle income countries in Mozambique. And I'm talking about prior to the work that we started doing in Mozambique. Then we have what's the human resource issue and the training of mental health providers. We're doing much better here than we do in other countries. However, I want to point out that the way that we do training is on individual care, and it's not in a public health, mental health focus. So we, in medicine, in psychiatry, nursing, social work, the majority of the training that takes place is how you work with your patient, perhaps with a family, perhaps with groups, but not within a system of care. So we lack that in our training. Psychotropics prescribed within the public health system. It's happening in the US and New York State. Not so much in low and middle income countries. People are not trained to use them, and therefore they're not part, and sometimes they don't have enough for them. Evidence-based therapies tested, definitely have a plethora of them in research that has been done even in our own institution. Yet how they're being used in or have been tested in low and middle income countries also is low. I'm going down first to talk about policies and funding. Many countries in low and middle income countries do not have established policies for that. In the last few years, even Mozambique has established a much better policy with regards to that, not because of us. They were doing it on their own, by the way. I don't want to take credit for that. But in many countries, the policies don't exist. And the other element is the funding that the government provides for mental health. And what I put in the bottom of that row is that less than 5% of the budget for health is used for mental health in the US and many high-income countries, whereas in low-income countries, it's even below 1% in some places, and minimal. And then with regards to the evidence-based therapies tested, the idea of adaptation to context and culture is very important, and it's needed even in our country. And why do I say that? Well, the reality is that our interventions are yet to be implemented to address the needs of disadvantaged populations and racial and ethnic minority populations, which therefore we continue to see how they are disproportionately affected and not treated by the work that we know so well how to conduct treatment. So it may be important for us to think in how they need to be adapted so that there is a yes in the column of US and New York. And evidence-based treatments within the public health system is terrible. Again, this may be happening more individually in private practices. However, systems of care tend not to integrate evidence-based short-term treatments. So today, I'm going to talk first about the column in green from Mozambique, and then I'm going to be addressing later the issues within the US. So let's try to give some solutions, right? It's time to not just problems, but try to figure out how to solve issues. So even if we train residents, psychologists, social workers, and nurses to conduct evidence-based interventions, to be adopted by clinics or systems require methods. Thus, evidence-based interventions adoption requires buy-in, or as we also say, want-in from multiple stakeholders. And it is our job to engage them into doing that. Otherwise, we're not going to change what's taking place. So if you think about this, an evidence-based intervention gets included within a system. First, the patient and the provider have to want to use it, want to be part of it, want to, for it to happen. The organization has to be also in agreement with that. Providers work within a public health system that is organizing clinics, and then you also have the structure and how to respond to that. And when we think of patients and providers, we need to think of the impact of family, friends, neighbors, social determinants of health, and health inequities. We don't tend to think about that when we are trying to provide care. And on the other hand, we also need to understand the socioeconomic and the political context, the governance, the policies, the insurance and reimbursements, how much a hospital is willing to spend in hiring the proper personnel to provide, and also societal norms and values. Stigma affects how things are distributed and money gets distributed. So to understand a little better what I'm talking about, all of us who have done clinical trials are always thinking of what are the patient outcomes. We need to look at clinical effectiveness. And by all means, that is the endpoint. We need to make sure that the patient gets better. When we're talking about services research and implementation science, we also have to look at services outcomes. Is it safe? Is there equity? Is everybody having access, or is only a few people that have access to it? The efficiency, wait list, time for it to happen, and timeliness. But also to be able to address, to get there, we need to make sure that whatever we're implementing is acceptable, is feasible, gets adopted and penetrates the system. There's uptake, but there's fidelity, right? Because the fidelity of a pill is very simple, but the fidelity of an intervention requires much more efforts. What are the costs to be able to do that? And definitely how to think of sustainability. One of the elements that implementation science has been moving towards in the last 5 years is how do we look at the sustainability of anything that we're implementing? And this is, when I talk to my fellows, whatever they are in the world, in the programs that we have of training, is that there are 3 words that I always want them to remember, which is sustainability, sustainability, and sustainability. If anything that we're doing is not sustainable, we're wasting our time and it's not implementation science. So I want to talk a little bit about these training programs and what we've been doing since 2012 here at Columbia. We're very proud of the work that we're doing together. So with Maria Oquendo in 2012, we got the T32, then Melissa became a multiple PI with me, and now I'm running it with the help of wonderful people, Jean-Marie, Francine, Cristiane Duarte, and our T32 has had impact with fellows working in many parts of the world, including when we say global, we don't mean international, we mean low resource, so including the US. And there we have 10 graduates, 4 current fellows, and 5 care awardees, and 4 tenure track positions within our team. We're doing pretty well, we're very happy. We also have to have global partners. So we first got a Fogarty Capacity Building Grant, that's from NIH, in Portuguese-speaking countries in Africa. Then 3 years later, we were there to go for the PRIDE study that I will describe today that also has capacity building. So it's a study in Mozambique with capacity building in 4 other countries. And we have been able to get 5 supplements to contribute to the work that we're doing as we discover more need. And also an NIAAA study in Mozambique using technology for alcohol use reduction. We also are now trying to replicate this in Asia with the amazing people of AMFAR Treat Asia, working in 4 countries in the region. So I'm going to concentrate today on the research study of the U19 and the NIAAA. Let me describe quickly Mozambique. It's one of 6 Portuguese-speaking countries in Africa. It only got its independence in 1975. It's the 6th poorest country in the world. It's 70% rural. However, 90% of the population can reach a primary care clinic within an hour. So, the feasibility of providing care there is very valuable. The HIV rate in the country is between 9 and 19%. And by the way, I didn't put it there. Epilepsy is very high also in Mozambique, very different than here in the US. The public health system is free for all. There are community level primary care clinics. They do not offer mental health care. They're not trained to prescribe psychiatric medications. We are changing that. And there are urban districts and provincial level clinics and hospitals. The public mental health system is also free, but unfortunately, it's only in urban mental health specialty clinics. And there are less than 500 mental health specialists for 29 million people. They have, since beginning in 1993, in parallel to developing when the antiretrovirals were being rolled out in sub-Saharan Africa, and they didn't have enough doctors to provide care, they trained nurses to be medicine technicians. And at that time, in the early 90s, when there were 3 psychiatrists in Mozambique, they decided that they needed to create a task-shifting cadre of psychiatric technicians, that either nurses or college graduates that take 2.5 years, 3 years to be trained to provide treatment for diagnose and treat psychiatric disorders with medication and psychosocial interventions. And there are about 150 psychologists and 18 psychiatrists at hospitals in the country. And that's it. This is what they have. So the 300 psychiatric technicians was an amazing, task shifting where people with lower training were trained to do the work and do it very well. So in implementation science, to ensure the sustainability of our work, we always try to work with policymakers and the community to determine priorities. What are the disorders? What services do we need? How can we implement them? And what would be contextually appropriate, acceptable, and feasible? So one of the fellows in our D43, Lydia Govea, who last week stepped down from being the director of the mental health department in the Ministry of Health, and another fellow of us, Wilsa Fumo, became the new director. Now Lydia is an advisor to the minister in Mozambique. She could not come up with her pilot project for her PhD work. So the question that she was asking, because of course, if you're in charge of the mental health of the country, you cannot do a little study. So we had to think of a large one. So what she was thinking all along, they, meaning the psychiatric technicians, were just a few. And it was easy to supervise them as they were continuing to grow. And now that we're thinking of how to provide better access in rural areas, they want to ensure quality. How can they do that? So we thought a little about it, and we came up with a research question that became our U19 grant that it was funded in 2017. Which pathway can adopt and provide care more effectively, looking at patient outcomes, while increasing access, looking at implementation outcomes. So we have 3 pathways. Pathway 1 is usual care at the district level, which is what's taking place now with psychiatric technicians. Then in pathway 2, we have clinic level care, where we have the community health workers screen and refer to clinics for treatment where the medicine technicians provide all psychiatric care. So moving it from the district to the clinic. And then a 3rd pathway, which is moving it to a combination between community and clinic level care, where we have the treatment split between community health workers that can do the evidence-based treatments and the clinic providers to do the psychotropic medications. So working with Melanie Wall and our group in Mozambique, we have come up with the randomization in 1-to-2, where we have 3 districts, 8 districts, and 8 districts. And the calculation of how many people we may have reached is that this is the number of community health workers in each of the arms, right? And because they treat between 250 to 500 families, we use the 250 as the minimum. This is the number of families that we may be reaching in our study. I showed this to you before, and as you see, there's a typo there. Hybrid effectiveness and implementation outcomes. We look at all of those outcomes. So in our study, we're going to be looking at implementing the training and the services for 1 year. Then we supervise for 1 year and look at outcomes, and then evaluate for 2 more years after we use the best of the 3 pathways in the rest of the pathways. In order to do this work, and by the way, the research does not pay for care. So the plan here, again, is sustainability. So we wanted to make sure sustainability, sustainability, sustainability. We wanted to make sure that once the research funds were not available anymore, the ministry would be able to continue with the services. But to provide comprehensive mental health care, we needed to figure out a way to assess for mental health. And we created what we call the mental wellness tool. So with the help of Melanie Wall and Kel Basaraba, we needed to think, okay, how would we create an all-purpose mental health screener, which can be used in a low resource setting? And we need to identify a wide range of psychiatric disorders. We need to be very brief to be implemented by community health workers and primary care providers also. So we met with the directors of primary care and community health care in Mozambique, and we asked them what would be the number of questions that we can ask. And they said, well, 3 to 6, and maybe more after that. But can you start with 3 to 6? It's like, wow, for all psychiatric disorders, a complicated business. It also needs to be reliable and valid, and with direct interview when you're talking to the patient, and with a proxy informant. And why that? Community health workers in Mozambique go from home to home, and they don't have the time to meet with everybody. So they tend to use a head of the household, somebody that they know. They go at least once a year. And if there are issues, then they go back. And they talk to that person who's pregnant, who's not doing very well, and a kid with diarrhea. And they bring issues about vaccination and provide vaccination, et cetera, et cetera. But not everybody's at home. So the idea with a proxy informant is that can we ask a question to the head of the household that would let us to go to the individual who may need care. So it needs to be able to screen as well as triage. It has to be sensitive to identify any mental health problem, and then specific to triage, specific treatment. So the issue here is that the screening needs to align with treatment. With work with the ministry and our collaborators in Mozambique, we had determined what interventions were acceptable, feasible, and with testing already done. So interpersonal counseling, medication, safety planning for suicide, and motivational interviewing, and vetting an expert became the answers of the interventions that we were able to treat, that we were able to provide. Therefore, the screener needed to triage to those. So the idea is that we could use diagnostic categories to be able to determine who needs what. So the goal was to have a proxy a questionnaire with 3 items, more or less, that would be high sensitivity because we don't want to miss anyone. If there was any positive, then how do we go to the person who was identified by the proxy and ask the same 3 questions, again, with high sensitivity because we don't want to lose, we don't want to miss anybody who needs help. And then by adding 9 more questions, the idea is to balance sensitivity and specificity to then determine what diagnosis categories were used. So Melanie and Kel came to us after they did beautiful work using LASSO, which is least absolute shrinkage and selection operator, logistic regression. And the shrinkage parameters were identified at 3, 5, 8, and 10 items to be able to reduce according to the categories that I have on the right, what questions we needed to ask to be able to have a balance of sensitivity and specificity. We also did expert consultation with selection of items. We did not want to use just LASSO. We wanted to make sure that it would pass the clinical judgment of those working in the different areas. So we met with multiple consultants to be able to look at that in our institution and others. At the end, the items that we determined to use to develop the best screener were 99 items addressing psychosis, mania, depression, anxiety, PTSD, and you have them listed there, substance abuse, and suicide risk. We also were hoping that the HUDAS, which is a disability assessment, would be used initially as a screener to start with disability and functioning to then move into diagnosing, but actually it didn't work. So we started with 99 items. Oops, it went too fast. And the idea was to be able to predict using a gold standard. We use the MINI as the gold standard to be able to predict. And the work of prediction has been used in previous studies for other disorders. So the mini and the screeners were used with two samples. First, developmental of the mental wellness tool in Maputo in 3 large clinics, and the validation thereafter when we had the measure, the screener, in another region in Nampula city, which is the capital of the province of Nampula, which is the most populated. And you can see over here the distribution of the disorders. But remember, we were talking about categories. So over here you have the distribution of the categories. And the most important part of what we all know when we're doing work that it's not at the beginning of T1, which is the comorbidities are very likely. So we were looking at categories, but as you can see in the figure, they intersect in the different disorders. And we had 47% of them that didn't have a disorder, okay? And this is how, after doing the lasso, how the mental wellness perform. So we wanna first address any disorder, right? Which is only with 3 items, as we were talking before. And we do it any disorder, and then for proxy that we tested it with family and non-family. And the idea here is to look at the sensitivity. So we have a 0.94 sensitivity and 0.73 sensitivity. And thereafter to look at the categories, to look at the specificity for these categories. So how does it look at the end? So we do case identification that you can start in the clinic by asking the patient directly the first 3 questions, and you have there the items that are being used. And with 0.94 sensitivity, we know that I have to continue. So the idea here is 1 step to go to the second step of 9 additional items, and you have them also explained here, to be able to determine, I'm sorry, common disorders, severe disorders, alcohol and substance use, and suicide risk, and because they're linked to the treatments that we were gonna be introducing. And over here, you have the sensitivity and specificity of them. And as I've been telling you, we also have the 3 items with the proxy to be able to determine who needs to be assessed. So in this study, what are our innovations? Number 1, it's sustainable, sustainable, sustainable. It leverages existing resources. We're not hiring anybody new. The research funds only pay for training and not for clinical care. Training a local cadre of trainers and supervisors that can continue the work after the fund is gone. And technology remains post-study of what we try to do, and I'll talk about that in a minute. It's the first study to provide comprehensive mental health care. All previous studies have done 1 or 2 or even 3 disorders. Ours was crazy enough to do comprehensive mental health care. The mental wellness tool is novel, brief, efficient, and valid, and allows to identify cases and triage those in need of care. And all interventions are evidence-based. We examine how to incorporate short-term treatments within a system of care to treat chronic conditions using sequential and combined treatments, addressing severity and patient choice. And 100% are shifting, which means it's coordinated by mental health specialists, but all providers and supervisors are either community health workers, medicine technicians, or supervisors respectively. Enthused by the work that we were doing, we then wanted to think of a dissemination study. In this case, which treatment delivery option, not by whom, but which option can provide care more effectively, looking at patient outcomes, while increasing access, implementation outcomes. So in this case, instead of thinking who would do the case, is should we use expert, which is screening, brief intervention, referral and treatment for problem drinking, either in the traditional or conventional training and supervision, or by a mobile using technology. And we have the distribution between 4 districts and 1 to 2 with 8 districts to be able to test that, and as I explained before. So what we do here is the following. You have a tablet, you have a community health worker, and he rings the bell, and my dog probably is gonna start barking, and everything that it's being done, it is immediately through the Wi-Fi for everybody to have access to. So stimulated by this study to the innovations that we had to the first study, the one that looks at who and not which, we decided to move on to do digital interactive tools that will guide providers to, number 1, use the electronic mental wellness tool, the evidence-based interventions that we've been talking about, while enhancing fidelity. Number 1, if it guides you in a very interactive way, you follow what it tells you. but we also have an ability to look at the metadata and how much time you spend in a screen. And if you do 20 screens in 2.5 seconds, or if you take 20 minutes in one screen and do the others, we can tell that, and we can do constructive supervision of what's taking place. Providing real-time supervision and quality control, we know immediately when there's suicide risk. And also it can be connected to developing an electronic medical record, which would be the new clinical chart in mental health, but that can be used for another type of all health conditions. We're working in trying to figure out how we combine efforts with others. And the idea is to promote sustainability. So what else does technology bring to all of these? Number one, who's using it? We know constantly who's using it. The GPS can also help organize. This is what we sold them to, the community health workers, because all the tasks that they're supposed to be doing automatically can be organized for them to be able to determine what needs to happen in the next few weeks and where to go which day. As many of you may do, and I'm sure Melissa does that within residency, we use technology for trainings and certification process. And what we do is to certify somebody, they have had to have at least 3 successful cases completed under supervision. And this is the incredible task that we're putting together. And this is what I say, that the Mozambicans are amazing. We created a trainer of trainers, and according to mental wellness tool, medication, safety planning, interpersonal counseling, mobile expert, or the traditional without technology, how many trainers we have, the psych technicians that are trained, there are 15 of them, we're not training them in this, and then primary care providers in the different modalities, and community health workers. Unfortunately, 2 cyclones last year and COVID have interrupted our training activities. But one interesting thing that happened is that this number of psychiatric technicians, which is the usual care on arm 1, and these are the psych technicians of the arms where we do evidence, the ministry, based on COVID, decided that they were going to implement our tools within the psychiatric technicians in the rest of the country. So the new usual care includes using our technology that has evidence. So the expansion is dramatic. So let me show you very quickly a little bit of the, you cannot get the whole taste, but this is our tablets. And then, we do SBIRD, and in SBIRD, we have anything from looking at what they're drinking or their drugs. We're able to do assessments and provide, for example, some issues. If you click in any of them, you can understand some of the issues that may affect your body. The I means information. So whoever is the provider using the tablet can click on here and get the background behind each frame to help them in case they have a question. So everything is at their reach. In interpersonal counseling, the beautiful work developed by Mirna and her late husband, and and that we're using, you can have the issues of how to understand the seek role, the interpersonal inventory. And I'm just showing you a few little slides of what's taking place. This is a very beautiful way of putting the people in your life, and then you can locate them, how close they are to you. And as you can see, it can be that they're helpful in your life. I don't know if you can see here, they're helpful, or in distress, or it's connected to support. So you can even give a sense of how they function, how they are part of your life for the work that will take place later. And then through questions and interactively, we determine which one is the area that the patient is going to be working on. And then in safety planning intervention, we began with the CSSRS for the suicide risk. And thereafter, we move on to, after the assessment, to figure out the level of risk and what you need to do if they are in rescue protocol, if it's high, and then to understand what's taking place if it's too low, and verify it. But if needed, of course, we go through, provide the psychoeducation, and this was developed by the Mozambicans with us to make it relevant for the population, and the therapist, the provider, can turn around and show and explain. And then it starts asking about warning signs, the safety plan, and the methods that they have thought about using, et cetera, et cetera. So this is just a little touch of what's taking place. The issue here also is, how do we work to embed these evidence-based interventions within a system? So most studies are, Milton is depressed, he goes for IPC, he does very well, we reassessed in a month, we're fine, and we can follow up perhaps in 3 months, and it's fine. But that's more of like an efficacy trial. In looking at an implementation study, we also want to see what happens across time for the sustainability and the management. So we needed to think together with them, which is what we probably need to think for what I'm going to be talking about in the US, is how do we incorporate what we need to incorporate in a long-term basis. So let's start with safety planning intervention. Somebody's suicidal, and in our study, we show that 85% had either of the other diagnosis categories. So once we know that Milton is safe, using safety planning, it can be referred to be any of the other interventions, right? But there was 15% that they didn't have. We thought that, we had a limit to how much we needed to train. I know that there are other interventions for besides safety planning. Maybe those are our next steps. If people are interested in working with us in Mozambique, we would go into interpersonal counseling where the interpersonal issues are very importantly addressed, which, as we know, can be an important element of suicide if they're not in need for other treatments. So that is with that. On the other hand, somebody can show and have positive for alcohol and depression. So the choice is made when there's comorbidity, either by severity or choice if the severities are similar. At the end of the treatments, we assess again, and we can determine if the person has improved. We reassess in 4 weeks just to make sure, because we don't want to just pretend that it's gone. And if still improved, we discharge and we do yearly assessments. Remember, community health workers visit the families and can ask again. And of course, we tell people, come back if you need us. Then if they're worse, then it means that maybe we missed something when we were screening, and it goes for further diagnostic assessment. But remember, this is only 4 weeks, and we're looking at the timeliness and the efficiency of these to make sure that people don't wait too long. And if it's the same, we have developed a short-term group motivation interviewing and interpersonal therapy that it will be short-term in the sense that every 4 weeks somebody can come in, and every 8 to 12 weeks somebody can leave. If they continue in need, then we refer for diagnostic assessment. So funding is already in place, thinking of next steps for adolescent mental health care. Kate Loveros K is addressing that and doing a beautiful job. Intimate partner violence, that it's prominent and an issue in the region. Jennifer Moots, also Mozambique, it's going to start next year. And we also have developed a collaboration with Ruben Gould at UPenn to do neurocognitive disorders. The next steps, and we're working with some wonderful people here at PI, is to look at medications. We know that meds are not enough to treat psychotic disorders, so we're looking into what we can bring to Mozambique in that area and to incorporate the community, and definitely drug treatment, that it's not there. So the question is, we're doing this in Mozambique. Can this be applied to any system? And remember, Mozambique has very few resources. So let's get to the last point of my talk, which is the COVID-19 supplement that we got. We convinced, NIMH was very stimulated by the fact that we have developed all these measurement and technology. And the idea was, can we bring it to the US for the COVID pandemic? So it's rethinking services to address the existing mental health disparities that will be exacerbated by COVID and the aftermath. And I'm going to talk a little bit about the implementation. And it's very poignant that last week, Kelly Kelleher talked about what we've not done a good job and what we need to do to implement better things. So let's talk about our supplement. So STEP Mental Well is bringing electronic mental wellness tool to New York Presbyterian. The first aim is to understand the mental health outcomes among COVID survivors and their families across time. Aim 2 is to combine telemedicine with work that Natalie Moyes has been doing in collaborative care to do electronic shared decision-making tools for patient preference for depression. I'm sorry, and the mental wellness tool that we created in Mozambique. And in the third aim, we're going to do a small pilot mixed methods to examine the feasibility, acceptability, and what are the factors that influence the implementation of what would be the combined STEP and Well tool in preparation for a larger grant. So let me remind you about the need, right? We've talked about this before. This is what depression looks and for youth in the US. So previous existing mental health disparities among racial and ethnic minorities are worsening in the COVID-19 crisis and its aftermath. The pandemic has highlighted these overall health inequities that we need to address. And a study that just came out on Monday with senior Nora Volko in the paper in World Psychiatry, as you can see, it confirms that patients with a recent, within the past year, diagnosis of a mental disorder have a significantly higher risk for COVID-19 infection as compared to patients without mental disorders, and also present a worse outcome as evidenced by higher rates of hospitalization and mortality. So it's here, it's real, and the disparities are incredibly strong. Also, in looking a little bit about how to understand services, I came across about the beautiful work of Mark Olson, our our colleague, esteemed Mark Olson, and we actually even had a conversation about this. And if you think about patients in mental health care, they looked at the dropout rates, and 60% of patients drop out of treatment only after 4 to 6 sessions in mental health sector and 3 sessions in the general medical and human services sector, which means we have very little time to keep people within care. And these are people with diagnosis. This is not just anybody. These are people that need care. And we also know that we constantly have shortages of mental health providers, even in New York, even in our system, where we have a plethora of providers that are able. So we always have waiting lists. And I was talking to Laura Mofson the other day, same thing happens in child and adolescent care. And once a patient, part of the problems that we have is that once a patient, always a patient, and sometimes in a weekly basis, until they drop out. And of course, some drop out and some don't, and we continue treating those that don't. But can we do something better? Even if we have enough providers that may be available, reimbursement issues maintain the mental health providers shortages, and that's a problem that I know that Warren is constantly facing in the hospital. Our training does not focus on a public mental health model. We are beautifully trained to see patients chronically on a one-to-one basis. And even if we train to use short-term treatments, it is more than a one-to-one, and we sometimes use the short-term intervention, and then we continue doing all the things until something else comes in. But that means that the ability, and I first saw this when I started working in HIV clinics here in New York City, where we had like 12 mental health providers on a clinic of 5,000 patients at St. Luke's Roosevelt, and all of them with HIV. Half of them needed mental health care, and there was never room for them to be seen by anybody. We need to change how do we provide this. And the issue is that systems of care do not organize their services to use short-term treatments. So can we think about what we're doing in Mozambique and replicate it here? I don't know. Not every patient needs to see a mental health specialist, and step care models are indicated. And that's something that I'm going to bring up in a minute when we talk about their supplements. So we know the needs, we know that there are disparities, we know that there are dropouts, and we know that services can be implemented a little bit differently. We need to address health equity and equitable implementation. These are foundations of dissemination and implementation research. And another element of implementation science is de-implementation. It's when you stop or abandon practices that are not effective, that may no longer be considered evidence-based or are potentially harmful. You revisit and evaluate the evidence base and health impact of previously implemented treatments, and you de-implement, but you de-implement using research methods to prevent terrible outcomes. I don't need to tell all of us what not preparing for a proper deinstitutionalization took place, and how many patients were lost and not treated in community settings as supposedly was going to happen. So how do we address those things? We need to do more task shifting, where mental health specialists train non-specialists and supervise them to do the work very well. There's some issues of reimbursement, but I've been speaking with Linda Rosenberg, and there's some ways around it. Linda, maybe one day we can talk more about that. And then integrated care. This is where you integrate it in primary care. And I want to talk now about how do you do step care model, where individual needs are matched to the appropriate level of care. More intensive intervention is only used if required. So you start with low intensity, with self-help and patients doing for subthreshold disorders. Then as the intensity gets more, you step up the criteria, you utilize more intensive and expensive treatment. So then you use evidence-based interventions, but they can be done by multiple peers, case manager, nurses, social workers, and residents. So we train them in how to use them within the system of care. And as more specialized, expensive treatments are needed for complex cases, you can do medication by multiple primary care providers. And then the real complex cases are the ones that we psychiatrists, psychologists, and residents can do. And by the way, this doesn't mean that there's not going to be room for us to continue working, because all of us over here need to supervise what happens, all of us down here. So even though we see few, we are incredibly needed. And that's the plan that we're trying to figure out for what we're going to be implementing. We just got the grant last week. So this is just telling you our plans, where we do the, in the follow-up of the COVID sample, we're going to be assessing them, and according to the combination of the telemedicine, case identification, and the patient choice and our tool, we will do step 1, step 2, step 3, and step 4, as I just mentioned. The issue is that IPC, ESPER, and SPI will be delivered individually for 4 weeks via telehealth using the apps. After the last session, patients will be reassessed to determine for the treatment need. Those whose assessment shows full or partial remission will be reassessed, and we may not to see people for life. Remember, there are many of them that only want to come and can come for a few sessions, and we can grab them and take care of them. If the findings from the initial assessment determines the presence of both, as I explained before, patient choice or severity, and if you continue screening, you can offer sequential treatments. Those who do not improve during the first treatment will be referred to 3 or 4, according to severity for medication management. Patient is initially referred for step 3, medication management. Once they're more stable, they can also participate of step 2 and getting interventions. And I believe this is my last slide, and we will keep you posted of what we're able to accomplish and hopefully to get into the R01. I've been working with Melissa, Eileen, Warren, and others, and Lou and Lisa to figure out how to bring these to our system. Thank you for your attention.
Wonderful. Thank you so much, Milton. Really just such impressive work. Just thinking about the number of systems of care that your work deals with, and just the logistical hurdles, the number of participants, just thinking about it is exhausting. I don't know how you shoulder all of that. It's really, really amazing.
Well, you saw my acknowledgement slide. We are a team, and I don't want to take credit. There are many of us, Milena Melo in my team and others, Jennifer, the T32 fellows, the people in Mozambique. It's been an incredible, beautiful, fun thing to do.
Wonderful. So I was going to start out with one question. So I absolutely hear about the role of the physician in a different light, and in providing supervision and consultation, and that being a larger part of the work that we should be doing. But I guess one of the things that worries me a bit about that is that I think for most physicians, one of the most gratifying aspects of the job is the one-on-one relationship with your patients. Mm-hmm. And I guess I'm wondering how you think about that tension, and if you experience some pushback from physicians wanting to have more of that immediate contact.
So it's very fair what you're saying, and it's very normal, especially because we're trained and we enjoy the training that we get. And number one, we don't have to stop, because remember that the complex cases come to us. And also in the training, we do role plays and we treat patients in front of others. So it's not that we stop, because if we stop, then we can actually not continue training and supervising, right? You can only supervise on something that you're good at and that you are still good at after years go by. So our role changes a little bit, that it's partially seeing patients, and the most complex probably. Nobody's eliminating private practices if people want to have it, including in Mozambique. You can continue having a practice where you see your patients. But if we're thinking of the system of care, we need to be much smarter, and we need to think how to reach who we are not reaching. It is very clear that we're not treating the population and there's need. And our role can be amazing in training others and supervising others and still seeing patients as we're doing that. There will be pushback, but there is a need, and I believe that we need to do something about it.
So I was going to turn it over to Dr. Lieberman, who I think has a question also.
Milton, actually this came from the Bible, but the colloquial translation is, "Why are you hiding your light under a bushel?" So, you're a big thinker. This is really incredibly important work.
Thank you.
And most of your work leading up to it was more focused, whereas this is like, this is going for the brass ring. It illustrates sort of two things. One, how, we're, meaning our faculty at PI in Columbia, are really at the forefront of trying to address the critical issues in mental health care. But two, it also illustrates what I've come to just appreciate and admire about this place, which is exemplified by so many different people and individual stories, how they got here, how they developed, how they arrived at a point of accomplishment and success in a particular field. So, Maria certainly is exemplary of that. There's so many people. So you came from Venezuela, you went to medical school there. It's good that you got out when you did. And you were at Mount Sinai, and then you came here to work with Anka and the HIV Center in a focused role. And then you evolved to doing your own independent research in that area and extended it to substance abuse. And then now this, and it just shows how, I keep repeating this, but coming to Columbia and PI is the opportunity of a lifetime of opportunity. And you really exemplify that. And by hiding your light under a bushel, I guess I just mean that I wasn't sufficiently aware of the scope of what you're doing. So congratulations. Two quick questions. On the last slide that you showed, where you got the COVID supplement, what target population or area, geographic area is that focused on? And then the second question is, what you describe in terms of a population health approach or strategy for public mental health care seems spot on, including, and I do appreciate Jonathan's sensitivity to the role of the physician. But medicine in general and psychiatry in particular is too physician-centric, and we can't hold on to that because it's just not going to work on a population scale level. So we have to figure out, but what you're saying about this intensity of care approach is really the right strategy, I believe. But the thing is that you can have a plan, but what is the convening or implementation authority? Because what happens repeatedly in this country is that great innovative approaches for specific problems are conceived of and enacted, but it's all sort of one-offs, bottom up, not top down. So I'm not trying to make your job, turn you into a politician or a policy person, but I wonder what your thoughts were about that too.
Thank you. First, number one, thank you so much. You're absolutely right. The amazingness of my colleagues at Columbia has stimulated me to be able to do this. I started as a clinician who was working in mental health and HIV when there were no HIV treatments. And it was a very difficult time. And I integrated myself within HIV primary care. And I realized that we were not doing well in providing mental health care for these people because there were not enough of us. So that has been a bug in my head throughout, and it has probably been the stimulus in the progression of my work. Even within HIV, my first study was how to bring HIV interventions for psychiatric patients to the city of Rio de Janeiro, which was crazy, but it was fun to work with the city. And so with regards to the population, the study is based on a COVID sample that was recruited from people who were discharged from the hospital after they were hospitalized, or they were visitors to the fever clinic during the COVID times. There's still some, but it's much less than what it was at the beginning. And they have about 1,000 patients. We're probably going to focus more in the ACN, the people who are in the clinics, because of all the regulatory issues to be able to do the work. So there will be about 400 and 500 of them that we're going to follow across time, and that we are going to get their input to figure out how to develop this. So that's the population that we're talking about.
Is your hospital collaborator Rafi at Lantigua?
No, actually, it's within that group, you have Ian Cronish and Natalie Moyes. They're the leaders of the work that has been taken. We've been meeting since March, I think 19, every week, following what's taking place and trying to figure out what screeners to use. And they have been very collaborative, and they're part of the supplement in the work that we're doing. They're amazing. It's a wonderful learning experience also about the amazing work that they're doing. With other diseases, because they're also looking at cardiovascular, neurological, etc. With regards to, you pointed to something that it's incredibly important, and I mentioned at the beginning, which is you need to work with policymakers. And Lisa has been helpful with that. Tom Smith and I have had some conversations. We're having some conversations with New York State. As you know, those are processes that take place. And in a way, I think that hopefully this COVID supplement will allow us to have something internally that would allow us to work with them and think a little bit bigger as we pilot things, because the idea of the supplement is to learn what we need to do. And I have to learn so much because, our system is very complicated. Reimbursement, you have substance abuse on one side, mental health on another side, who gets paid, who cannot get paid, what the hospital is willing to give. I also think, there's an element because in other parts of medicine, they have organized themselves in a way that you have physician assistants, you have hospitalists, you have different people doing different things. And somehow, and I know it's not us, it's more like the combined issue is that reimbursement, stigma, the issues of mental health are very complicated. And we have not yet been able to do that. And I think it's time for us to, this is an opportunity. So I see, unfortunately, COVID is terrible, but it's a phenomenal opportunity for us to say, people, we can use telemedicine, we can use technology, but let's figure out how do we do a system where we can provide care, because there are a lot of people who need it, and we have very little access to them, and they don't have access to us. So you're absolutely right in that process. I need to, and I hope that I made it clear that this is only work that can happen if we work collaboratively between all the stakeholders that are involved. Otherwise, nothing is happening. And it's also a process of understanding, okay, how do we get there? How do we get there? And Jonathan, that is beautiful to do, because when you're trying to help your amazing people surrounding you, when you're talking about the pushback, if we can also start thinking, okay, how do we use everything that we know to move it to a level of more public mental health? It's also an incredible experience and very fruitful, to be honest. So part of my hope today is, even though I did touch some Achilles tendon in some of the things that are taking place, is to stimulate the process to figure out how do we do more of what we need to do better and to help more people and enjoy what we do. Because I'm that, I'm a one-on-one trained person, yet I'm loving the work that I'm doing because of the impact that we can have.
So there were two questions that came up that I wanted to run by you, Milton. So one is, when you're thinking about and developing something like the mental wellness tool, how do you balance the need for it to be, on the one hand, culturally specific and sensitive to the population that you're working with, versus on the other hand being generalizable and moving it from Mozambique to New York? And then the other question, somewhat unrelated, but was, you mentioned that the rates of epilepsy are strikingly high in Mozambique. And any sense for what the explanation for that is?
Okay, so let me start with the second one, epilepsy. So unfortunately, there are multiple issues of parasitic infections, traumatic events, malnutrition, that all combined give a higher rates of epilepsy. And actually, psychiatrists in Mozambique are also treating epilepsy. There's no neurology. So anybody that gets treated for epilepsy is treated within psychiatry. And as of a couple of years ago, only psychiatrists, our colleagues there in Mozambique, with funding from the WHO, they're implementing an epilepsy program where they're training primary care providers, just like we are talking about. And that was the impetus to do what we're doing, to treat epilepsy. And I did include it today because I didn't want to disturb the whole population, is that our mental wellness tool also then asks for measures validated for epilepsy, and we train people in doing epilepsy, or sort of like refresh the training, and we have it also in our tablets to make sure that there's fidelity and electronic medical records of what's taking place. It's their reality, and so we can only have access to treat them. And it's been amazing. Primary care providers are so happy that they were able to treat people that were suffering with epilepsy. And one of the work that we're doing is we're working with some technology people and trying to figure out how to do EEGs in a simple way to help with that process. So I'm doing things that I've never done before, like EEGs, but that will be in the future. With regards to the validation measure, you're absolutely right. It's a perfect question to ask. And by all means, we need to validate it. What's interesting also around the world is that many measures are used in multiple settings without them being validated. Funding for validations don't exist. The way that I do it is because I get from here, and try to figure out how to do it. It's not in the grant as something that we would do because nobody pays for it. But it's something that we're doing. So with Melanie, we're trying to figure out, we already have a group in Madrid that did some data collection for this there. We're about to do that also within our supplement to figure out how do we quickly validate the measure. And it is complicated. At the same time, at one point, and please don't kill me when I say this, perfect is the enemy of the good. And we send our children to schools and we don't know that they're perfect schools, but they need education. So at one point we need to think, can we implement and measure and do something that implementation science does very well, which is a dynamic validation of things. Can we start implementing and at the same time assess the validity of things so then we can go back and improve it, which is how science works, right? In your studies, you find out something now that you didn't know before, and you may go back to MRIs and look at things that were done before that you were not thinking about, or that you would do a next stage of combining things. So the learning process is very important. It's not static, but it does require cultural adaptation and validation, definitely.
So I think our last question is if you could say a bit about the role of stigma and particularly if that manifests in ways that are distinct in Mozambique relative to the United States or other areas where you've worked.
Well, stigma of mental illness is huge. I can tell you that even in my first grant in Brazil, which we were not expecting to work on stigma issues, which was about HIV risk behaviors among psychiatric patients. The first day of our ethnographic work, because we do combine mixed methods, qualitative and quantitative, one of the research assistants was approached by a patient in one of the units. The units there are in the open, great weather. So instead of being in a hospital unit that it's closed, there's a big open garden in the middle. And they announced we're here to do, we're going to look at sexual research and sexual activity and issues with psychiatric patients and HIV. And immediately one of the patients came to her and said, can you choose your partners? And she was trying to figure out, why is he asking that question? And she said, I guess I do. And says, well, I can't. Being a psychiatric patient takes away my ability to choose who's going to be my romantic partner and my sexual partner. And sometimes I just have to say yes to whoever wants me because I want to be in a relationship and I want to enjoy my sexual life. And that makes us think like, oh my God, nobody has thought about how within even the HIV world, the psychiatric morbidity makes you at more risk for HIV, and we develop a measure for that. As we work in different areas of the world, including in the US, psychiatric patients are not the centerpiece of where healthcare puts their efforts. And depending in communities, you're even seen as somebody who's weak, who is not, and that happens everywhere in the world. In Mozambique, like in other sub-Saharan African countries, traditional healers have also an important impact. What's interesting about Mozambique, it's an amazing country, I have to say, and hopefully they're listening and they're enjoying what I'm saying about them. it's one of the few countries that traditional healers need to be certified by the Ministry of Health. And they go through a training to make sure that, and this started with antiretroviral treatment, because if you treat HIV with by traditional healers, not using medications, you're in the wrong track. And they did very important work to make sure that the traditional healers would do the right thing with regards to HIV. The same task is taking place with mental health. There's work within the ministry, because you can be a spirit, you can have a spirit, and that's why you have psychotic disorders. But the same thing's for epilepsy. So it goes from the weakness of being suicidal to the being, possessed for having severe disorders. But the country is changing. Our ministry team and the people in Mozambique are doing constant, the 17 of them are doing amazing campaigns constantly. And we are collaborating with that. We did a very important awareness campaign. We work with the Minister of Health, and it's been an amazing experience. But stigma, and it will be there, think of, the Jewish community in Brooklyn, even in small pockets of communities. Think of stigma of mental illness is very complicated, but we have to address it. And we in public mental health have to make sure that we do everything to reach people and not to allow that stigma, and even our own stigma, because not everybody in health wants to treat psychiatric patients because of that. Therefore, the morbidity and mortality that they have, that they live, 10 or 15 years less than the general population, a combination of access and stigma that they face. And minority populations in general are even worse with regards to that. We have not adapted our work properly to work with disadvantaged populations and ethnic and minority groups. And we need to do that. They're the ones who are suffering the most. And it's difficult, but it's amazing work if we can do it.
So I know I said that was the prior one was the last question, but one more question came in that I wanted to ask you. I think this is coming from Bill Pfeiffer, who I believe is doing some work in South Africa. And so the question is, how are collaborative efforts going with other sub-Saharan countries as part of your Pride initiative? Beautiful question.
So and thank you, Bill. And also Bill and I are planning something, so it's fun. Hopefully in a year, we'll tell you some things that we're planning together in Mozambique. We are trying to do multiple collaborations. We're trying to do collaborations in genetics. Carlos Pato, with other groups that are doing genetics in Sub-Saharan Africa, is going to be working with us to do genetics in Mozambique. And we are working with how to bring Pride to other countries. It's a process, and money is required. At the same time, we're working how to expand within Mozambique as the COVID-19 epidemic is happening. So with the group that we collaborate in South Africa, the Foundation for Professional Development, we are trying to figure out how to bring our work to Rwanda and to South Africa. And it's a very active time and trying to figure out, because COVID is opening, unfortunately, yet is opening opportunities, fortunately, for us to try to help others.
Okay, terrific. So thank you again, Milton. That was a real tour de force, and such important work and such impressive work. So thanks a million.
Thank you so much. And I look forward to work with many more of you here at Columbia.
Wonderful. So for the department, just for everyone to know, next week, we're continuing with our global mental health focus, and Vikram Patel will be presenting our grand rounds, and hope everyone can make it. Thanks so much.
Thank you so much. Take care.